At the outset, I would like to thank this governing body of SRNM, Society of Renal Nutrition and Metabolism, for choosing me for this audition. Thanks Professor Bhalla, Dr. Georgie sir, Dr. Shwanlata and Dr. Tiwari sir for these kind of introductions. So, when we talk about, we understand I have written one obituary on Dr. Anita Saxena that has been published in Indian Journal of Nephrology in 2022. You have heard a lot about Professor Anita Saxena. This was the prayer written by her. Here, three important stalwarts are here to witness that Dr. Anita Saxena has mainly written this, and Dr. Georgie and A.K. Bhalla is here, and every year during this inauguration meeting we used to have this prayer. So, coming to the topic, metabolic associated chronic kidney disease, a way forward to prevent and treat. Just a new terminology, old wines in new bottles you can say, but you can see just this was a person 160 kg, came to me in OPD, he has diabetes, he has all dyslipidemia, he has problem of the coronary artery disease, he has multiple problems altogether. So, really should we label them, this is the patient is the type 2 diabetes, diabetic kidney disease, or should we have this metabolic associated chronic kidney disease where the obesity can independently may be responsible for progression of the kidney disease. So, metabolic associated chronic kidney disease is the new terminology, multiple synonyms you can see, metabolic associated CKD, metabolic dysfunction associated CKD, metabolic disorders associated CKD and metabolic associated kidney disease. So, a lot of new terminology came. When we look at this is not a new terminology, evolution of the metabolic syndrome CKM syndrome here we can that started in 1920 and gradually insulin resistant era came, that has been introduced into the definitions, then syndrome X came into the pictures. But for all practical purpose, when we have 3 or more, when you have the low LDL, low HDL, high triglyceride, fasting blood sugar is high, blood pressure is high, waist circumferences are bigger, 3 out of 5, if it is there, then you can say this is a metabolic syndrome. So, when you look at this paper, just we have published 3 countries, India, Korea and China. There you will see prevalence of the hypertension and the CKD patient is almost similar. 2 are different, Korea and China, whether these are the countries which is exercising more and taking care of more of the metabolic syndromes. So, core drivers of the metabolic associated chronic kidney disease, when you look at type 2 diabetes, responsible for glomerular hypertension and glycation injury, obesity, again hyperfiltration and lipotoxicity, hypertension causing glomerulosclerosis, dyslipidemia, renal lipid intoxications. Lipid like this fatty liver, lipid in the kidney can independently injure, cause the lipotoxicity of the kidney. Metabolic associated liver disease or fatty liver, the similarly it can be the fatty kidney. So, insulin resistant again responsible for endothelial dysfunction. When I am looking at this CKM, that is another topic there, this is how there are different stages, no risk factors stage 0, when only you have the risk factors, no typical disease, it is a stage 1. Stage 2, when the similar risk factors leads to like the diabetes, hyperdyslipidemia and hypertension, metabolic syndrome kind of the situation, then it is stage 2. When subclinical manifestations comes, it is stage 3. When overt clinical manifestations comes into the picture, it is stage 4, metabolic cardiovascular kidney metabolic syndromes. Majority of the patients falls into the group of the stage 2, where 40 to 50% patients lies here, and core drivers of this stage is diabetes, hypertension and dyslipidemia. When we look at here in the stage wise, most important alarming factor is that it is more common in the female when you look at this lower infographics. So, is the adipose tissue of the lean or obese individuals are different? Yes, someone very lean and very healthy can have the adipokines, more inflammatory stage, but obese patients fat cells are very much obese. They have more pro-inflammatory cytokines like TNF alpha, interleukin 6. So, but at the opposite times when the fat cells from the lean persons, it has usually the more of the IL-10, interleukin 10 that has anti-inflammatory effects. So, fat tissue in the two different persons are different. Other important risk enhancing factors for the CK arm are usually, particularly when look at the female proportion where we do not take into the account during the history taking the premature menopause, adverse pregnancy outcomes, polycystic ovarian syndromes and erectile dysfunctions. These are the some of the factors. Social determinants of the health are also very important and that is not taken into account by nephrologists when we are taking this history of the CKD patients. So, metabolic syndrome and kidney disease, when you look at the two different studies, third NHNES studies, when they have compared those who do not have the metabolic syndrome, adjusted odds ratio for developing CKD was 2.6 and adjusted odds ratio for microalbuminuria was 1.89. In another non-diabetic cohort, when they have followed adjusted odds ratio on multivariate analysis for developing metabolic syndrome in CKD patients was 1.43. Metabolic syndrome and kidney disease, when insulin resistant cohort was followed for the 6 years, here we can see 254, 9% of the patient develops albuminuria. Waist circumference was positively associated with this onset of the new microalbuminuria, although fasting blood glucose, lipid and BMI was not associated in this insulin resistance cohort. CKD definition we all understand. What I want to emphasize today, once the diagnosis of CKD is confirmed, the primary cause of the metabolic associated coronary disease should be determined through detailed clinical history taking, physical examination and further investigations whether this is really a simple diabetic kidney disease or whether this is associated with metabolic associated chronic kidney disease where multiple factors including the hypertension, dyslipidemia, CKD, MBD disorders, hyperparathyroidism all are responsible for progression of the kidney disease. So, in true sense all this should be labeled as MACKD, metabolic associated chronic kidney disease rather than writing only the diabetic kidney disease. Here what we can see with the staging, in stage 1 or 2 mild nephron loss, stage 3 moderate nephron loss, stage 4 severe nephron loss, marked fibrosis, reduced GFR. Needs to see at which stage we are looking at and what would be the actual dietary prescriptions and what would be the actual prescriptions to retard the progression of the disease. Impact of the CKD on health, 114 global cohorts, over 27 million individuals. This cohort was shown that the factors which are responsible for progression or adverse outcome in this group of the cohort of the patient was significantly high when these factors were the kidney failure requiring RRT, all cause mortality, cardiovascular mortality, acute kidney injury, any hospitalization, CAD, stroke cohort and all cardiovascular problems. So, CKD toolkit is very important and we all understand any persons coming to OPD should be put on this toolkit and what we can see, patients in the green should be screened and should be 6 months, every 6 months preferably at least once a year. Those who are in yellow and orange, we must treat these patients because here is the scope of the full reversal of the progression of the disease. You can revert stage of the microalbuminuria, you can reduce the degree of proteinuria by treating the lot of newer medications which are available now in the market. This is the paper, just we have written one review, it came last week in the journals, clinical endocrinology and metabolism journals, and where evaluation and management of metabolic associated CKD, how it is important, anyone can have look at it. So, management of the MACKD Mediterranean diet or DASH diet that we all understand, I will not going to talk about. Weight loss, but nobody had time to say how much weight loss should be there. Whether the patient is going to lose 10 or 12 kg in the 3 months or 1 month. So, we should have given the target 5 to 10% loss is associated with improvement in BP, insulin sensitivity, albuminuria and inflammatory markers. Calorie intake, how much calorie we should restrict, that for that we do not have the time. So, 600 kilocalorie restrictions can be advocated per day. More than that the patient is unlikely to tolerate, and that results into the improvement in insulin resistant and reduced GFR. Protein intake I am not going to talk about, and dietary sodium restrictions, that is important. Non-pharmacological intervention, other important intervention is her exercise, 150 minutes per week. We all understand that improves the insulin sensitivity, reduces visceral adiposity and preserves muscle mass. But what we do not take care when we are looking at the patient with the metabolic syndromes are obstructive sleep apnea. That has lot of major adverse effects on day to day life. Ambulatory or home BP monitoring, masked hypertension is very common in our group of the patients, that is not taken into the account. Yesterday there was very good class on exercise, how it can improve. So, I am not going to talk about, but it is very important in day to day practice. Blood pressure control, that we all understand, systolic blood pressure. Everyone knows about this, the blood target of 130 by 80 or by KDIGO it was given 120, but we must understand that 120 if your patients tolerate. If it does not tolerate, 130 by 80 is fine for all group of the patients. Non-pharmacological intervention, 4 pillars we all understand: RAS blocker, SGLT2 inhibitors, pindinone and GLP-1 receptor agonist. We understand the target: RAS blocker, afferent arterioles, SGLT, proximal tubules, pindinone, MR receptors and GLP-1 metabolic plus cardiovascular. All have different kind of the mechanism of actions. So, we must remember. So, adding all drugs together might be more beneficial. First pillar, RAS blockers. HOPE study in 2000, ramipril reduced cardiovascular mortality. Renal study, losartan slowed CKD progression independent of the BP. IDNT study, ARB was superior to amlodipine, and IRMA 2 trials, early RAS blocker prevents nephropathy onset. So, this was something. Despite so much of the strong evidences, when we have analyzed the data, prescription of 4,000 prescriptions of the Indian nephrologist, what we have found, despite eligibility, only 48% of the prescription had RAS blockers. So, due to some reasons, it is quite possible that we are not adhering to the guidelines, and because of the slippage of the patients from the clinic, there might be some apprehensions to some of the nephrologists, but we should take into the account now with a lot of evidences. Second pillar, SGLT2 inhibitors for cardiovascular outcomes. Again, what we can see here, all cardiovascular directed outcomes have again shown a reduction in the cardiovascular mortality. When SGLT2 inhibitors on renal outcomes, 3 important studies, Credence, DAPA-CKD and IMPA-Kidney study was already there. All have shown, no need to explain too much of the details. Everyone is convinced now there is lot of beneficial effect with the use of the SGLT2 inhibitor, particularly in the initial phase. With the Credence study in 2009, 20, again DAPA-CKD and IMPA-Kidney in 2022 have all shown reducing cardiovascular and cardiovascular mortality and renal protections. Here we can see this was all the summary of Credence, DAPA-CKD and IMPA-Kidney study. Impact of SGLT2 inhibitors, a reduction of HbA1c of 0.8%, body weight reduction of 2 to 4 kg, systolic blood pressure decline of the 3 to 5 mmHg, albuminuria reduction of 30 to 40%, HHF reduction, heart failure ejection fractions, you can reduce, here we can reduction of the heart failure by 25 to 35%, and ESKD reduction by 28 to 40% across the trials that has been documented. Third important, non-steroidal mineralocorticoid receptor antagonist. Three important study in our hand, Fidelio, Figaro and Fidelity. Fidelity is the combinations of the both studies, population of more than 13,000 patients. Again you see composite kidney outcome reduction hazard ratio of 0.77, cardiovascular outcome protections hazard ratio of 0.86. So, this all have been based on the strong evidences, but this needs to be used in the day-to-day practice. Pindinone in heart failure and chronic kidney disease patient. When you have heart failure, chronic kidney disease again. Pindinone versus placebo, what you can see, death from any cause, heart failure requiring hospitalization, and composite kidney outcome was extremely good with the pindinone as compared to the placebo. Only cardiovascular death was not significant because most of these patients have at the baseline heart failure. Confidence trial, when SGLT2 inhibitor was combined with the pindinone, what you can see, the drop in the UACR, albumin creatinine ratio was almost double. It was 52% as compared to 29 and 32% independently. Hyperkalemia chaos always comes in the mind of the nephrologist, but my suggestion is always there. If the patient in the early phases, we should not stop any of the drugs causing abruptly. We should evaluate, stop temporarily, come back again, see whether this was the factors causing hyperkalemia was treatable, and we should reintroduce these drugs, particularly the RAS blockers and mineralocorticoid receptor antagonist. Fourth pillar, GLP-1 receptor agonist. First 4 trials was cardiovascular directed trials. Flow study was kidney outcome trials. Here we can see again risk reductions was 24% in composite kidney outcomes reduction with this use of the semaglutide. So, then again multiple meta-analysis has also gone into the effect that probably there is a lot of kidney composite risk reduction of 20 to 25% with the use of different kind of GLP-1 receptor analogs. Why combination works better? Because glomerular filtrations, 2 drugs, RAS blocker, SGLT2, hyperfiltration, again the 2 drugs, proteinuria, 2 drugs, inflammation, pindinone, fibrosis, pindinone, metabolic state, GLP-1 receptor agonists and SGLT2 inhibitors. So, combinations are likely to work better. Lipid, we all understand in dialysis dependent patient lipid control does not help too much, but in non-dialysis patients, again with this many of the newer drugs like the PCSK9 inhibitors are now available. You can use one time in once 6 month kind of situation of this injection and can give you the very good lipid controls. So, non-dialysis dependent patients, we must take care of this lipid metabolism. Hyperuricemia and CKD and outcomes, this is one of the component, hyperuricemia is one of the component of the metabolic syndromes. Here most of the study you can see no benefit, no benefit, no benefit, or only one study has shown Prasad has the reduced event. Otherwise, either it was neutral or there was no benefit. So, treating asymptomatic hyperuricemia is not that useful as per the practical evidences suggestive. One of I have already told you, we should also understand lipid toxicity through the kidney is equivalent to lipid toxicity in the liver. So, here we can see the association, advanced CKD 60 to 75% MAFLD prevalence. So, very high prevalence. 1 in 4 or 1 in 3 patients with MAFLD had concomitant metabolic associated chronic kidney disease. So, we must take into the account whenever you are looking at the patient of the MACKD, we should also evaluate patient for the MAFLD or MAFLD for the. So, and the same kind of the drugs, taking care of the insulin resistance, inflammation, obesity and RAS activations can have the impact on the both kidney impact and liver impact. And so, you are taking care of the both liver injury and kidney injury. So, this is all the different study have shown the benefit of these drugs are enormous in taking control of this MAFLD or MACKD. So, can they be started simultaneously? This is the normal questions asked everywhere. Yes, drug like ARB and SGLT2 inhibitors can be started together, pindinone, GLP-1 receptor, they have the different actions, different pathway. But starting all together can increase risk of hypotension, AKI, hyperkalemia, and volume depletions. So, we must keep into the mind when you are starting all together whether your patient is likely to deteriorate, and so that should be in the mind. So, recommendation: first, start RAS blockers, step 2 add SGLT2 inhibitor, step 3 add finerenone, and step 4 add GLP-1 receptor agonist. When not to stack quickly, when your potassium level is high, more than 5, symptomatic hypotension or advanced AKI is there, then we should not start all together. Then definitely we have to take step by step. What does it mean? In the present time, renal progression or GFR decline should not be more than 1 to 2 ml per year. It was the very older concept that 5 ml per minute per year was the faster progressors. If you are starting at the GFR of 30, when you reduce this progression of the kidney disease to 1.5 to 2 ml per minute per year, dialysis requirement would be in 10 to 14 years. So, you can delay the dialysis by 5 to 10 years. So, it is very important to know the stage 3 and stage 4 where you can have the maximum benefit of using these drugs. Social determinants of the health is another important that we do not take into the account while taking the history. I already talked about economic stability, education, food, community and social context, that we should also take into the account. Implementation of the established clinical guidelines is always poor in South Asia region. So, this was the one paper which we and Dr. Rajiv Agrawal, who was one of the pioneers in GLP in a finerenone study. We have defined several reasons why we are not able to implement these guidelines in South Asia. There was a similar kind of the KDIGO Asia Pacific Implementation Summit on diabetes and blood pressure on CKD. I was one of the members. Again, we have emphasized there are several barriers in our regions. Major studies on reverse epidemiology, I would like to take 2-3 minutes more. Reverse epidemiology is always in our mind. Since beginning, we understood that dialysis patients, obese patients do relatively better with higher BMI. Effect of metabolic syndrome, when this is our own study, when we have studied in the peritoneal dialysis patient, followed these patients for 5 years, what we have observed, metabolic syndrome is an independent risk factor for mortality in peritoneal dialysis patients. So, another important study which we have followed and patients of the peritoneal dialysis patient, underweight diabetics were at higher risk of mortality as compared to non-diabetic patients. And we have also observed those patients who were obese has higher risk of developing peritonitis. So, ladies and gentlemen, think beyond DKD when you have patient with a type 2 diabetes. MS-CKD prevalence is very high, particularly in the South Asia region. Target should be the Asia specific, 23 for overweight, 25 for obesity, not the 30. That is the Western data. And we should try to add on RAS blocker, SGLT2 inhibitor, NSMRA and GLP-1 receptor agonist if permissible and indicated. Optimal therapy delays requirement. Diet as medicine should be practiced all across. Oration is dedicated to my parents whose attitude towards education made me eligible for this oration. I would like to thank one of my mentors here, Professor Amit Gupta, Professor R.K. Sharma, who taught me ABCD of nephrology. Last year, I have got College 3 from our Patna Medical College, Patna, on the 100th years of centenary celebrations. And thanks to all my faculties, all my students, staffs who are the working force behind it. So, this is our renal and transplant immunology lab. These are my collaborators. Many of are here, but I would like to acknowledge at this moment Akhilesh Jaiswal, who is working at Gangaram Hospital now, Dr. Vikas Agrawal, Dr. Brajesh, who has got PhD, and Dr. Vinita Agrawal from pathology, who worked with us. Thanks to millions of the patients who showed confidence and faith in me, and maximum brand goes to my family. My wife, who is professor of gynae ops in Queen Mary Hospital, KGMU in Lucknow, the similar kind of the BG department. My son who has passed just MBBS from FMC Pune. My daughter has just completed +2, having the all India rank 1 in ICSE board +2. So, but I will not escape thanking Indian Society of Nephrology. Since the beginning of my career, Bansal audition in 2006, Vidyacharya audition in 2003, and then Bisa Rodi auditions of NACONS, Kulade Award audition of 2013. So, lot of blessings, lot of you can say favoring me for all these auditions and recognitions. So, thank you, ladies and gentlemen. Thank you for your kind attention, and thank you again.
Thank you very much, Professor Narayan Prasad, for an excellent, very educative audition in the fond memory of our Professor Anita Saxena, who has made this founder of the society. So thank you very much. As for the, we do not ask any questions and answer in this session, so that I'll give the mic to Prasad.
I will request Dr. D.S. Rana, who is the founder patron, as was made by late Professor Anita Saxena. Dr. Rana was the founder patron, and I will request Professor Amit Gupta also to come on the stage.
सुजीत सर आ जाइए सर श्रीजीत हाँ अर्पिता मैडम Dr. Srikanth, you can also join us.